Dr. Sumana is a very distinguished cornea specialist from Calcutta and our very own alumni. And she's going to take us through infective keratitis. Can I ask Dr. Jaya to please join us as a panelist?
Very good morning to all my esteemed colleagues, and thank you so much, Shweta, for including me in your IC. I will discuss some pertinent points about pediatric infective keratitis. And as we all know, that natural curiosity, immature motor skills, tendency to imitate adult behavior, all of these make children adorable. But at the same time, they do not understand the harm with dangerous objects like plants, metals, plastic parts, fireworks, and pencils, and they may cause the ocular trauma. And it constitutes the costliest societal burden, with imminent risk of amblyopia and or permanent visual loss, and it comprises 3 to 13% of keratitis cases worldwide. So, incidence of blindness caused by keratitis in children is 20 times higher in tropical developing countries like us with poor healthcare when compared to developed countries. And a study from Indian subcontinent mentions childhood keratitis to be among the most common causes of unilateral corneal blindness, accounting for almost 36.7% of cases, though in this respect there is wide variety in the geographic distribution. Usually the diagnosis is delayed in children because they cannot give proper history, and most of the time they do not complain of ocular pain, and parents also not serious about the complaints. The primary care physicians, mainly not ophthalmologists, they confuse keratitis with the less severe conjunctivitis. Reports of microbial keratitis in children have shown a bimodal distribution of ages: preschoolers between 1 and 3 years, and adolescent contact lens wearers. The male-female preponderance varies between studies and geographical locations. In India, usually males are much more affected. So, what makes childhood keratitis more risky than the adult keratitis? There is difference in risk factors, and the adherence to topical medications is a challenge, and they have more severe inflammation than adults. So the main predisposing factors for countries like us are ocular trauma. In developed countries, from the contaminated solution or biofilm associated with the contact lenses, systemic diseases like protein energy, malnutrition, prematurity, and incomplete immunization profile. So contact lens use in children should be cautiously advised, especially with other risk factors like pediatric rosacea or recurrent blepharitis. And this constitutes the local predisposing factors like chronic steroid use in vernal keratoconjunctivitis and blepharoconjunctivitis, ocular rosacea, previous surgeries, congenital facial paralysis, previous herpetic infection, dry eye, exposure keratopathy, and eyelid abnormalities. Usually the organisms are gram-positives, and increased incidence of keratitis are seen by coagulase negative staph. Multiple resistance to antibiotics is very common, so an antibiogram should always be performed. The culture positivity in pediatric patients is less because most of them are already on antibiotic. The microorganisms may show slow growth on culture media. There may be viral causes of keratitis, improper corneal sampling, and inherent difficulty in getting corneal samples from children. In case of post-traumatic infections, the staphs are predominant. Fungal infection are seen in tropical countries like us. In contact lens user, Pseudomonas takes the main onus. Herpetic infections, it is prevalent in children, but it remains often undiagnosed or misdiagnosed. In a study in South India, it has shown where fungi is a main pathogen, Fusarium being the predominant genus, and North India still shows bacterial etiology predominantly. So we can use monotherapy in case of small ulcers less than 2 mm or non-serious paracentral ulcers fluoroquinolones for gram-positive, amikacin for gram-negatives, and natamycin for fungi. Voriconazole 1% may be supplemented for large and deep fungal ulcers not responding to treatment, and combination therapy with fortified antibiotics may be necessary for extensive ulcer, non-healing or progressive cases, and deep infiltrates. The surgical interventions are required for perforating ulcers and corneal scars, and attending to corneal scar is very important to obviate astigmatism, visual deprivation amblyopia, and post-op amblyopia management for the visual rehab of the child. This is one of my patients who had a penetrating trauma resulting in an corneal ulcer and this kind of staphyloma when he was 6 months old, and we did a PK for him, optical PK, and this is a 1.5 years old child, and the smile says it all. If we come to the neonatal keratitis, the most common agents are bacteria, followed by herpes simplex and then fungi, Pseudomonas being the most common. And in case of the neonates, the typical reactions like pain, tearing, redness may not be very pronounced, and surgery for them may not be possible if their physical condition is not favorable for GA. Eyelid abnormalities in them may predispose to the bacterial keratitis. We have to keep in mind about the maternal genital tract infection for HSV and gonococcal keratitis, and prematurity being a factor, and multi-drug resistant nosocomial infections in NICU is always troublesome. Now, vernal keratoconjunctivitis per se is a contributory factor apart from the steroid use and trauma in increasing the risk of corneal infection, even by innocuous opportunistic organisms, because they have abnormal immune response to indigenous bacterial flora. The physical barriers to bacterial flora, there is a breakdown due to cytotoxic elements released from mast cells. The normal antimicrobial activity of tear film is compromised by reduced level of lactoferrin, that is an iron complexing protein with bacteriostatic property. And Staph aureus can be isolated from the lid margins of most patients with atopic keratoconjunctivitis. The typical features are stromal infiltrates which develop usually underneath the calcific plaque of shield ulcer. So this is difficult to diagnose initially. So a sudden increase in redness, irritation, and dimness of vision should raise a suspicion. And also, if the shield ulcer is resistant to the traditional anti-allergic therapy, we should always take suitable cultures. Though rare, fungal keratitis can also develop under a plaque of a shield ulcer. This is a 6-year-old VKC kid who had a history of severe eye rubbing, developed keratoconus, developed eye drops, and as we were waiting for GA fitness, the child was on topical steroid and he came back with this kind of a Pseudomonas ulcer. So this is not very uncommon. So minimum use of steroid and concurrent use of topical cyclosporin A is advocated because the studies show cyclosporin A has some anti-fungal activity. Coming to the pediatric herpetic keratitis, the typicality is the bilateral involvement is extensive, and they are more likely to have stromal keratitis, which has both immune and infectious components. Stromal scarring and opacification are more severe in children because of their robust immune response. The maximum daily doses of acivir in children is 40 to 80 mg per kg daily. With stromal disease, the prophylactic therapy we continue for at least 1 year after the episode. And recurrence is much more common in children. The immunodeficiency, organ transplant, atopy, all as they increase susceptibility to the infection, they can significantly be associated with recurrence, as we can see in adults. After the disease is quiescent for 1 year, the prophylactic therapy can be discontinued with close follow-up, but if additional recurrences occur, indefinite use of acyclovir with renal function monitoring should be practiced. So the difficulty in administering therapy is intrinsic to the young age, but could be overcome if the caregiver, particularly mother, is convinced about the effectiveness of the long-term treatment. The next important thing is multidisciplinary approach with pediatric infectious disease specialist and pediatric ophthalmologist and close clinical follow-up. And last but not the least, the role of counseling. The more chair time you spend with the patient and the parents, the more favorable outcome you will get in these cases. Thank you so much.
Thank you, Sumana, for a very nice